Hi, everybody. My name is Aviva Klein, and you may know me as the CEO and founder of the University Blood Initiative. But tonight, I'm going to be your MC as we discuss sickle cell disease in America. So we have two wonderful guest speakers, Dr. Ward from UCLA and Mapillar. And I'm not going to spoil too much of their background because I want them to be able to tell their own story. So with that, Dr. Ward, would you be able to introduce yourself first?
Yes, hi, I'm Dr. Ward, Dawn Ward, and I am a clinical pathologist with a subspecialty in transfusion medicine. And so I'm the medical director of the Blood and Platelet Center, which is a donor center with UCLA Health. I'm also faculty with David Geffen School of Medicine at UCLA. And I'm very happy to say that we do have a University Blood Initiative group with our undergraduate UCLA campus. Thank you for having me today.
And my name is Mapillar Dahn, and I must say, Dr. Ward, I'm excited to be having this conversation with you with everything that you do in terms of blood. One of my daughters has to have monthly blood transfusions. So people like you are near and dear to my heart. But as I said, my name is Mapillar Dahn. I am the founder of MTS Sickle Cell Foundation. I started the organization in honor of my three daughters. They all have sickle cell disease. So I'm very passionate about everything sickle cell awareness, and I'm appreciative for this platform, UBI. Thank you guys for having this conversation with us. It's wonderful because sickle cell is very underfunded. And so, but the fact that it's a complex disease and it allows us to do stuff like this, because even though UBI, you're not about sickle cell awareness, the fact that our mission intersect where that blood, that blood piece, it allows us to use your platform to educate more people about sickle cell. And so thank you so much for that. And thank y'all for having me. I'm looking forward to this conversation.
No, don't thank us. We're thanking you for both of your times. And, even though our main, drive is blood in general, our whole piece is engaging diverse communities and diverse communities' needs. And part of that is sickle cell, because it's not fair to fight for, more blood and shares without saying, hey, these are people who need it the most, right? I think we can all agree on that here. Absolutely. So with that, I would like to feature the fact that some of the questions I will be asking tonight are from our wonderful UBI Instagram followers. And in true Zoom COVID fashion, I turned everything off but my phone alarm. So I'm sorry about that. But with that, I'm going to start off with a very basic question, just to get it flowing, get everybody comfortable. So what is sickle cell disease? And of course we have the mother patient perspective and the scientific clinical perspective from Dr. Ward. So perhaps Dr. Ward, you can kind of start us off, and then Mapillar, you can maybe go into what is sickle cell in your perspective in your daily life, maybe.
Sure. So sickle cell disease is actually a group of blood disorders, and it's inherited from one's parents. Now, sickle cell anemia is the most common and severe form of sickle cell disease, and that's typically the one that, when we say sickle cell disease, that's what we're referring to. Sickle cell anemia is actually a mutation in the hemoglobin. And hemoglobin is a protein within your red blood cells. And hemoglobin is an iron carrier for your red blood cells and also an oxygen transporter for your red blood cells. So with this mutation in the hemoglobin, it prevents the red blood cells from being very malleable and movable, right? So typically our red blood cells, they flow through our vessels, they go to the very small vessels, our capillaries. And for that reason, they have to be able to change shapes and, make it through these very small diameters. With sickle cell anemia and with this gene mutation, the hemoglobin cannot change shape as easily and it becomes very rigid. And so that causes the cell to actually change into a sickled shape. And then when the red cells need to pass through those very small diameters, like in the capillaries and such, they can cause occlusions there, which can be in turn very, very, sorry, my phone is on as well, which can be very painful for patients, and as well as cause other challenges for patients as well. So it's really a gene mutation in hemoglobin.
And I think it's also important. Oftentimes, people don't understand that, unlike normal red blood cells that last about 120 days, sickle red blood cells last between 10 to 20.
Right.
So you have people who are going through life, and their red blood cells are continuously breaking down, causing really chronic fatigue and just different complications. Because sickle cell is a blood disease, wherever blood is on your body can be impacted. You know, there are people who go blind because of sickle cell. People are having strokes because of sickle cell. Um, we don't think about children having strokes, but sickle cell is the leading cause of stroke in children. And so just having to live with the implications of that, the social, physical, and sometimes socioeconomic impacts of that. Yeah, sickle cell is a very complex disease, very brutal, and it is very real.
Yeah, I think that was, a great answer to kind of a horrible question, if you will. But we don't often think about, well, when we do think about sickle cell and this whole body, whole life condition that it really is, and the toll it takes, just like cancer, just like diabetes, it's in the same level of impact. I don't think people truly understand that at times. So to go to our first UBI Instagram question, Vanessa wants to know, so how exactly, we mentioned before that sickle cell, is passed down genetically, but exactly how does that work? And I guess you mean, is it dominant? Is it recessive? And so on and so forth.
Sure. So it's an autosomal recessive inheritance. So essentially you would inherit each gene or each chromosome from each parent. And this is on chromosome 11. And so with sickle cell disease, you would have to inherit the autosomal recessive gene mutation from each parent. Now there's another way that you can inherit the gene, but if you have one normal, or what we call wild type gene, from a parent, and then the other parent could have a sickle gene, then that person would be considered sickle cell trait. So you often hear about sickle cell anemia, in which a person has inherited the mutation from both parents, or a homozygous inheritance, versus sickle cell trait. And that's when you will have one normal beta globin gene and one gene with the mutation, and those folks would have sickle cell trait.
And I think it's important to understand that, when both parents have the trait, with every pregnancy, there is a 25% chance that your child could have the disease. And I like to stress that because there's a misconception, even within the sickle cell community, that sickle cell skips generation. And it's just because of that, it's a game of chance. So I like to use my life as an example. I've had 3 pregnancies, I've had 3 births, and all 3 of my children have sickle cell disease. With every pregnancy, the odds are the same. If mom and dad both have the trait, there's a 25% chance that your child will have the disease. There's another 25% chance that your child will not have the disease nor the trait. And as Dr. Ward said, there's a 50% chance that your child will be a carrier and someday, possibly have a child with sickle cell.
Right. And as babies are born in the United States, they're tested for sickle cell trait and sickle cell disease. And about 1 in 13 babies born have sickle cell trait, and about 1 in 375 babies are born with sickle cell disease. So it's very frequent with birth.
Yeah, even I didn't realize how common it is, and yet how, again, on spoken about, I'm not to go down too much of a rabbit hole, but that myth that you were talking, or rather, I guess, misconception about, oh, it skips a generation. I guess, like, where do you think that comes from? And I guess where do these other, like, misconceptions within the community come from, do you think, Mapillar, in your experience, since you work with so many people like yourselves in your very wide network?
I think it's really because of the lack of education within our communities, and also just the fact that, a couple may have 5 kids and only one have the disease. So that give credence to someone who may feel like it skips generation, but it's just not true. Yeah.
Okay, thank you. So Sebastian wants to know, or rather, he's heard that, sickle cell disease is more prevalent amongst African Americans, but he wants to know why that's the case. Like, why is it so localized in this population? Who would like to go first? I think, it's fair game for either of you.
I can provide some comments, and I'm sure Mapillar will add some comments as well. So it's really an adaptive advantage based off of African ancestry. So the adaptive advantages for sickle cell trait is that the malaria parasite has a very short lifespan if it actually is engulfed by or is taken in by the red cells. As Mapillar mentioned, that red cells from sickle red cells only have a 10 to 20 day lifespan versus normal or wild type red cells that last 91 to 120 days. So the adaptive advantage is if a person has sickle cell trait and they're in a malaria endemic area, those red cells will die off quickly, right? And so if you think about African Americans in America, taken from Africa, it's something that has been carried over from the Middle Passage. So us coming from Africa to America, and it's an adaptive advantage. And as Mapillar mentioned, if you bring two people together with sickle cell trait, then there's a possibility for the baby having sickle cell anemia. And so that's really why we see it in African Americans more commonly than other races and ethnicities. But you do have some folks of other ethnicities that have sickle cell disease as well. It's just not talked about as commonly, but there are people of African descent that ended up in South America. There's also, folks in India and other places as well, where we do see patients with sickle cell anemia.
And if I can just piggyback off of the doc, I think what's important to note is that just depending on your ancestry, sometimes it'll determine which type, because there are different types of sickle cell disease. Dr. Ward mentioned sickle cell anemia, which is typically what we talk about in the United States.
Correct.
But if you are, if you have ancestry from, say, West Africa predominantly, or the Mediterranean or Middle Eastern descent, you may have SC, which is hemoglobin C disease. Or if you have beta plus thalassemia, your ancestry is more likely to be of Mediterranean or Caribbean. And I can go on. I have a list here, but basically there are different types of sickle cell disease. And I think what is sticky about the different types is the fact that sickle cell patients are unjustly treated because of if you have this type, you're not supposed to be in pain, or if you have this type, this is not supposed to be happening. So if they're exhibiting certain symptoms and they go to the hospital, they want to be healthcare professionals want to type them and say, well, you should not be in pain because you have this type of sickle cell. And so it's important that we know that there are different types of it, but it's also important that we know that sickle cell impacts everyone differently, even with the same type. I have 3 daughters who all have the same type, but for example, my oldest daughter is the only one who's ever had any pain crises. I have a 17, a 16, and a 12-year-old. 2 of them have never had any pain crises, which is unheard of. The disease just impacts them differently. My middle daughter had a stroke when she was 7, so she's the most impacted, has to have monthly blood transfusions, all that stuff. And they all have SS, and they're supposed to have the worst kind. But there's someone else who has a milder version who goes through so much more than they do. So it's important to know that everyone is impacted differently, regardless of what type of sickle cell you have.
Dr. Ward, do you want to comment on anything Mapillar just said regarding how patients may be treated by type classifications?
What can I comment? So we are aware that there are different types of different causes of sickle cell disease, and Mapillar is absolutely right. There's sickle beta thalassemia, there's hemoglobin S, hemoglobin C, and you are taught that perhaps this person may have a milder form of the disease based upon what changes they have in their genes. But as she mentioned, everyone is different, and everyone experiences symptoms differently, and so one thing I do like to advocate for patients is to really share their experiences with clinicians and providers when they're working with them. So despite what the laboratory value says, you really have to advocate for yourself and really explain, what you're going through, and hopefully, they will get on board with that and not just look at the lab value that they've received.
Yeah, and I think that, I think a good majority of our students are pre-health, whether it be nursing or pre-PA or pre-MD. This is a good lesson to take away about your patients, and that, the textbook isn't always right. And sometimes what your patient is saying supersedes what you were taught in school.
Absolutely.
In a lot of ways. So I think it's a good lesson to take away from that moment.
Absolutely.
So we kind of actually talked about this a little bit, but just to see if we have anything else to add. So we talked, are all forms of sickle cell the same? And I guess, the answer is, of course, what we just discussed, no. But Mapillar, I think it's a great opportunity for you to do a further deep dive, I guess, perhaps about this question, and also about your experience with the different variants of sickle cell disease and how they present and how they affect, and and any other way you want to take it, man. You are the expert here.
Well, not necessarily how they present, because we work with all patients, and honestly, I'm not on the medical side of things. I'm more socioeconomic, providing assistance to families. But yes, there are different kinds of sickle cell. Again, there's SS. Ancestry tends to come from Africa and India. SC, West African, Middle Eastern, Mediterranean, hemoglobin O disease. It's more Arabian descent, North African, Eastern Mediterranean. Hemoglobin D disease is more Asian, Latin America. I think it just it goes to speak to what is another misconception, because sickle cell predominantly impacts people of African descent in this country. It is seen as a Black disease. In this country, yeah, because it predominantly impacts us, but it affects so many people globally. Yeah.
Again, not to fall too far from our nice question list, but I guess how do you, again, we are in America. Many of the patients that you help locally are, of course, in America, unless you're on a different planet from us or a parallel universe from us right now. But I guess, how is this perception of sickle cell as being, a Black disease? I guess, how does it affect how patients are treated? How do you think it maybe affects funding or taken seriously? Like, what is the cost of that? Like, I want to say stigma or label.
Oh, we can go down.
We can go down the rabbit hole. We are ready for this question. This is why I'm asking it.
Well, because it is seen as a Black disease, sickle cell is very underfunded. When patients go into emergency departments with pain, they're oftentimes labeled as drug seekers, or that they're faking their pain just to get drugs. And the socioeconomic impacts of sickle cell, it's really why I started my organization, because as a mother navigating life with 3 kids with sickle cell, things does get very difficult. It is such an unpredictable disease that one minute everything is fine, next minute you're looking at spending at least a week in a hospital because of a pain crisis. And there just seems to be a systemic insensitivity to sickle cell disease, whether it is, we talk about the healthcare system, but just, I remember my daughter had a stroke because we were waiting for Medicaid to approve her for her insurance. And this is something that you see systemically, which is why conversations like these are really important, because we're building sensitivity. We're not only educating about sickle cell here, we're building sensitivity. The more people who know about the plight of the sickle cell community, the better. And I'm hoping that the audience will be able to talk, educate other people.
Yeah, for sure. Thank you so much for sharing that. I mean, I think it's very important for our audience, especially those that are interested in becoming physicians or nurse practitioners, people that will be working with patients in the future. You really should be sensitive to all patients, right? But specifically sickle cell patients. And I'm glad you brought up the comment in regard to drug seeking. When people present to the emergency room with sickle cell disease and they are in pain, they are truly in pain. And we should really take that seriously. And I know there have been challenges just with our healthcare system and with the emergency room, and actually believing that folks are in pain and not drug seeking. So for all of you that are interested in managing patients in the future, listen to your patients. Sickle cell, especially, they come in with pain and you should take them seriously.
And I think one of something that a lot of people do not understand is that because patients get mistreated so often, the hospital is the last place they want to come to.
Right.
And if they do come, it's like the last result. And some of them they're in pain, but they'll clean up nice, try to do different things to just minimize the odds of them being stereotyped as drug seeking. When, if I'm sick, I'm probably going to be in some sweats, going to the hospital because I need relief. But they feel the need to just clean up. Some people even wear like suits, just to be taken seriously. And the pain is real. Mm-hmm. The pain is so real. When sickle cell patients come into the hospital, please believe them. And I think a big part of it too is because sickle cell is not taught. There's not a whole lot, unless you're going to be a hematologist. Mm-hmm. It's not really taught in medical schools. And so just different misconceptions that may come into the hospital room with that physician, or, the little bit that they may know about sickle cell disease, and whether it's racial biases as well. But whatever it is, sickle cell disease is so real, you guys. It is painful, it is deadly, and oftentimes they really need your timely assistance. You have to be timely with some of the care that you administer, or it could be fatal.
Okay, Dr. Ward, if you don't have anything to add, I guess we will move on to the next question. And I do apologize at some point in the interview, I get a little overly emotional. It's just a lot of the points you're talking about, Mapillar, like really just resonate with me. And again, I don't have sickle cell, but I've had a lot of my own health concerns, and I had to do, maybe not to the extreme of sickle cell patients, but I've had to do a lot to be considered seriously. And I think that people in the audience, again, even if you don't have health concerns, even if you don't, again, like you don't have sickle cell, like think about a time where you weren't believed, or you needed help and no one was going to give it to you, you were being ignored requests, and what you had to go through and how it affected your life, and then put that in the context of a very deadly health condition. I think that would help kind of ground you in what Mapillar is talking about. And that's, the fact that someone has to be, deadly sick and in a suit is very, that kind of image in my head is really poignant. But just to keep on moving on, if you will. So we have three wonderful people, Janice, Jahid, and Hannah, all asked the same questions, and that is, what are the main symptoms of having sickle cell disease? And again, I think we've all discussed that everything is on a spectrum and people act differently, but still, I think that we can talk about it in some broad strokes. Again, from like the personal lived perspective from Pillar, you and your family and your wonderful daughters who I have met. They're wonderful girls, by the way, again. And also from Dr. Ward and the more clinical, I guess, textbook, and also maybe in your own patients that you've seen present. So Pillar, please take it away.
I'm trying to think about it because, one of our biggest issues after all what I just said is the fact that sickle cell is not an outwardly disease, right? Like if you saw my kids right now, you wouldn't know that something is wrong with them. So, but when my daughter is exhibiting, like if she's in a crisis, I can't touch her because I'm causing her more pain. She is in so much pain that all she needs is for them to give her some pain meds. And, it's morphine, it's really hard narcotics for, babies and people who are having pain crises. That's all they need. They need you to help alleviate that pain. And that's because their red blood cells has become clogged in their veins and they need fluids and medication and things like that to get them back to good. Another symptom that we experience here with my oldest daughter, she has jaundice a lot. And that's because, like we talked about earlier, the red blood cells, they break down continuously, and that buildup of bilirubin, it causes the eyes to be yellow. And so that's a point of feeling self-conscious, if you will. And sometimes people don't understand that. Some people may make fun of that. You have sickle cell patients. For example, my middle daughter who does the monthly blood transfusions, she has scars on her chest from her port surgeries. So, she may feel self-conscious about that. But sickle cell just affects everyone differently. Like I said, people go blind from sickle cell. Do you want me to go into the stroke? Like why?
Whatever you feel is needed to paint the picture.
Okay.
Truly, there is no barrier here.
Okay. So my middle daughter, Deej, when she was 7, she was in the 2nd grade, she had a stroke. And as I said earlier, sickle cell is the leading cause of stroke in children. And the reason for that is she has another underlying condition called moya, and the vessels in her brain are very narrow. So you combine that with sickle cell disease, she's at high risk of having a stroke. So she had a stroke when she was 7. She lost mobility. She could barely speak. Since then she's had to have monthly blood transfusions. And so I think that's how we met, because I'm always trying to get people to donate blood. And you heard about me. And so, yeah, we're always trying to get people to donate blood because especially people of African descent. And I think we're going to talk about that a little later. Trying to get people to donate blood, because if she doesn't get a transfusion, the odds of her having another stroke is very high. And so thankfully, since 8 years ago that she had that one stroke, she hasn't had another stroke. And that's because of those monthly blood transfusions.
Yeah, and other ways that sickle cell patients may present is with a fever, or sometimes they'll have chills. Of course, the pain, as we mentioned. I mean, if you think about it, if your cell is changing shapes, right, it's becoming sickled, and then it's actually clogging up your vessels, right? So then you're going to have no blood flow on the other side of where that clog is, and that can be very painful. You have the cells actually lysing or breaking open, so then you have the free hemoglobin, which can lead to fevers, and that activates all kind of chemicals and chemokines in your body, which results in the fever and chills and such. There's also the anemia piece, right? So as you're turning over red blood cells very quickly, then you don't have the proper amount of hemoglobin circulating on a day-to-day basis to supply oxygen to all of your tissues. And so there's the anemia piece of sickle cell disease as well. One thing that patients often present to the emergency room with is also acute chest crises, right? So acute chest is where it may actually look more like a pneumonia. So you'll have infiltrate into your lungs. You'll have a decrease in oxygen saturation, so poor oxygen exchange with your lungs as well. And that is a result of the sickle cell disease as well.
Yeah, I mean, again, to our earlier point, the sickle cell, I mean, there's some, I mean, the cascade of effects it can cause, I mean, it's just pretty staggering. And especially if for some reason you weren't diagnosed, you didn't have a genetic testing and you were going through a crisis, I can only imagine how long it might take for you to get diagnosed with all the possible symptoms going on, and where do you start first?
If I can just speak to that,
Yeah,
I'm so glad that you said that, because in other countries where there are no newborn screening, or if it's not universal to them, children do not live until age 5.
That's true.
You know, and so newborn screening has been very instrumental to even changing the trajectory of how sickle cell is treated here in the United States. And so, yeah, I think it's important that we all, because I'm trying to help to bring newborn screening to other parts of the world. I'm starting in Africa.
Yeah.
But yeah, we have to, there are so many countries, so many places that are affected by sickle cell that are not even a part of the global conversation. Mm-hmm. And that's because there's no data. A lot of these people don't even know that they have sickle cell because there is no screening. They're in remote parts of these countries. The healthcare system is poor. And so many kids who are born with sickle cell die before the age of 5.
I mean, yeah, I mean, again, those are pretty staggering statistics. As much as, you know, we like to have fun and joke, you know, this conversation, I mean, it centers around the fact that this is a very deadly disease, even with screening, as I guess you alluded to earlier, and that is the core of this. But to take us to have a more optimistic note, if you will, so what are the different ways of treating sickle cell? Of course, I will, you know, put a disclaimer that there is no cure. Like most genetic illnesses, you know, we're not at the point where we can change everyone's DNA in every single cell of your body yet, hopefully soon. But I guess a better question is, like, what are the the words escape me. We'll go with treat because I can't think of a better word at the moment, but you get what I mean. There's no real cure here. So I guess Dr. Ward, would you like to go first? And then again, Mapillar, I guess you can maybe talk about some of the treatments that you've seen and its effects and et cetera, in the more personal perspective yet again.
Right. So blood transfusion is one of the treatments that we do provide for sickle cell patients. The blood transfusions do a couple of different things. One, it can address the anemia, right? So it can increase your hemoglobin oxygen carrying capacity. The other thing is that by increasing that hemoglobin, it'll suppress the bone marrow from making more red cells. And so in turn, you'll have less sickle cells being produced. The other advantage with blood transfusion is to prevent the strokes. And so there was a study done with children, and they were able to demonstrate that with regular blood transfusions and actually decreasing the amount of circulating hemoglobin S, that you can prevent future strokes. And that's what Mapillar's daughter is going through that regimen, as we speak. So the blood transfusions are extremely helpful for sickle cell patients. They're not without risk, right? But that is something that we've shown to be helpful. Now, in regards to actual cure, there is a possibility for stem cell transplants, right? So you can actually do a hematopoietic stem cell transplant, and you would actually be replacing the erythroid or the immature red cells, the actual stem cells, with cells without that gene mutation. So that is something that is being done across the United States, stem cell transplant. And there's also a big push for gene therapy now as well. So you can take the cell, you can actually change the gene, and then give those cells back to the patient And that actually is curative for sickle cell as well. Still somewhat new, but has been around, still gaining ground. There's multiple researchers across the US, including at UCLA, that do perform stem cell and gene therapies for sickle cell disease.
And there are, along with the curative options, there are now more options when it comes to therapies. We went actually decades with just one drug on the market for a patient population that, as I said, it affects everyone differently. And of course, medications don't work for everyone. So, but thankfully, we're not gonna hold grudges. We have new therapies that are out and more therapies being worked on. This is a great, I've never been as hopeful for sickle cell disease as I am right now. There's just so much energy, so much buzz, so many new innovative, whether it's therapeutic or the curative options. Even with the cure, there's so many different ways these companies are looking at it with CRISPR technology. Some of them are turning on fetal hemoglobin. Some of them are turning the the trait on. I don't know how they're doing it, but it's like all of them have different techniques. And I was like, go for it. We need more people trying to cure this disease. But of course, it's not a universal cure until people in Africa and other parts of the world who are impacted by sickle cell, until they have access to these curative options, we are continue to go forward and continue to try to get help to everyone.
Okay, yeah. So I guess to kind of again focus on blood donation, since that is kind of in the name of UBI here. I guess spoiler alert, I guess everyone saw that coming here. But just going back on transfusions, and I guess to their efficacy in treating patients and preventing crises and so on and so forth. Can we talk a little bit more about that? Or even Mapillar, do you, and then people that you work with, or even your own family, do you know of anyone that gets or relies on frequent transfusions? So what we mentioned, your daughter. So, but if there's anyone else, and how they have been receptive in the experience of getting these transfusions for them?
Well, the therapy itself has been a godsend for our family. I cannot imagine, her quality of life without these transfusions. They have been successful in preventing another stroke. It's been 8 years. And I think, like the Dr. Ward said, while there are risks, the risk of being overloaded with iron is one of them. And she was actually overloaded at one point, but she was on a medication that, along with apheresis, which is, I don't know if you're familiar with apheresis, but they hook you up to a machine that takes out some of your blood and at the same time give you blood. So with that procedure, along with the medication, she's no longer overloaded. But that's something a lot of sickle cell patients struggle with, having iron overload, which could lead to organ damage. But transfusions have been a godsend for us, and they've been a godsend for so many people in terms of stroke prevention, or even preventing them from having sickle cell crises. What else can I say about transfusions? Yeah, I think that's.
Yeah, we don't gotta beat a dead horse. Then, what is our rhythm, I guess, for this talk? Dr. Ward, do you have anything to add to this topic?
Sure. Yeah. First of all, thank you to all of the potential blood donors that are listening to us.
Yes.
That's
we
really
love a guilt trip. We love a guilt trip here.
That's really what we need. We need blood so that we can provide blood to our patients, right? To help them through their disease and to feel better. I think Mapillar mentioned it. So there's different ways you can receive transfusions as a sickle cell patient. There's a simple transfusion, and that's just like 1 unit that you're being transfused. And what they've recognized is that 1 unit of blood is essentially, so if it's 500 mils or 300 mils, that's equal to 300 milligrams of iron as well. So when you give these one-offs, you do get that iron overload, and it can occur rather quickly. Now, the apheresis that she mentioned, that's really a great way to provide blood to sickle cell patients, because you're taking off red cells as you're giving red cells, right? So you don't have that same iron overload burden that you would with a simple transfusion. And then also just in regard to the fluid shifts and balances, it's much easier for patients as well. It's more convenient. Unfortunately, you do have to have a port, placed to be able to undergo this procedure. But you can be in and out within, or have the procedure within an hour and a half to 2 hours to have that blood red cell exchange occur. I guess one of the biggest challenges with the red cell exchange is you would need a specialized nurse, an apheresis nurse, to help monitor that procedure. And then it also requires more red cell units. So you would have to have more donors donating to have those red cell units available for those transfusions. But it does improve the quality of life.
Yes, and I would like to speak to what you just said as far as the specialized nurses, and that's bringing the pandemic into it. I actually just got an email from the hospital about 2-3 days ago that because of the shortage in nursing staff at the hospital, they're going to have to switch my daughter back to simple transfusions while they train people. And also there's a shortage of blood right now. I remember at the beginning of the pandemic, they did the same thing, but it was because there was a shortage of blood. And this time is the shortage of nurse.
Wow.
Yeah. I'm sorry.
Don't be sorry.
Don't be sorry. No,
this context.
This is where we are as a society right now. So
yeah. Do you guys? Well, I mean, I think it's an important. I don't consider this to be a tangent whatsoever. But do you guys want to talk about the effect of the pandemic on the blood supply, especially as it pertains to sickle cell patients? And we could even touch upon even before the pandemic, because I think we can all agree that even before, it was still not always easy to get the blood you needed. And the pandemic has only made things worse. And again, as our donor base continues to age, and as again, the majority of our donors are not the most diverse group, I will say it only makes the struggle worse. So I guess, what is your perspective on the state of supply? Mapillar now, in the past, in the future, and Dr. Ward, as always, I don't know why, but you're chiming in after Mapillar. I guess I'm just attracted to that lovely pink tank top that I see in my visual camera.
I'm wearing red next time. I think it's always been a challenge, especially for, it's been a challenge to diversify the blood donors list. But, in a pandemic where everyone is worried about what's happening with themselves and not really, not being reminded, I'm guessing, of why it's important to give blood. I'm not sure. Well, other than the fact that people are just busy with their own lives and trying to stay away from other people and not get COVID, and also probably wondering, is it safe to give blood? If they are wondering, it's just important that we continue to, put the messaging out there that, hey, sickle cell does not stop for a pandemic or these other conditions that rely on blood products. They are still here. These patients are still needing these services. And just remind people. We were on the news, I think, last month, trying to remind people to give blood because we still need it. But it's always been a challenge. And I think that the pandemic has just kind of put a spotlight on it. But for us and our population, it's always been a challenge.
Yeah, I wanted to comment on that, how you say with us and our population. And that's because for the red cells, they have different proteins on them, what we call antigens. And there's some genetic component of which antigens are expressed on the red cells. So people of African descent typically have a very similar phenotype or expression of proteins on the red cells. And so for sickle cell patients, because they're transfused so often, we like to match that antigen profile for the patient, so that will prevent them from making antibodies to foreign antigens. So unfortunately for sickle cell patients, the data demonstrates anywhere between 20 to 41% of patients will make antibodies, right? And making antibodies to a red cell makes it more challenging to get transfused in the future. Versus the general population, less than 3% of us will make antibodies to red cells. So for sickle cell patients, we like to map out what antigens they have on their red cells when they're first introduced to our hospital. And then we will try to match as many of those antigens up front to prevent them from making antibodies. So what that means is if the majority of your blood donors for your donor center are white, then that antigen profile on the red cells will likely be different than the patient population, which is majority African American. And so we really struggle with getting people of color to donate blood. And there's multiple reasons and historical reasons why that we really need to address within the transfusion medicine community to really encourage people to come out and donate. And they are directly, impacting someone's life. I know my red cell phenotype, and so I'm like a perfect donor for sickle cell patients. I mean, obviously I'm African descent, but that's really what we need to do. We need to encourage more people of color to donate. Now, with the pandemic, there is this thing called donor fatigue, right? So at the beginning of the pandemic, everyone went inside the house. All of our high school blood drives, and that's for UCLA, we would go to high schools to have these very large blood collections. All the high schools were closed in LA County, and so we lost a lot of our blood drives that we typically would have. And then we had the public appeal for donation from the Surgeon General, from the governor, from the mayor, and we got a nice group of folks to come out and donate. And then people got tired of donating. So at the beginning of the pandemic, we were doing bad because we didn't have drives. Then we had a nice group of folks come through, and then we kept calling them because we continually still need the blood. High schools are just coming back in this upcoming academic year. But donors just got tired. And so we're experiencing this donor fatigue where, as Mapillar mentioned, people are afraid of their own safety. Many blood centers are part of a hospital. They may not want to be, at the hospital. And then there's a fear of possibly contracting COVID-19 from, staff, et cetera. So it has been a challenge. We are still going through a blood shortage nationally, and we, really are trying to motivate folks to come out and donate blood.
I mean, I think
So if I can,
oh, go ahead. It's your voice is more important than mine in this conversation, please.
I wanted to add to the conversation about antibodies because
Sure.
my oldest daughter, not the one that gets the monthly transfusions, but my oldest daughter actually during one of her last transfusions when she had a crisis, she built antibodies to the protein JSB. Is that the right way you would say it, Doc?
Yeah, JSB,
Okay.
yes.
So her she built antibodies to the protein JSB, which is found in 99% of the US population.
Yes.
So she is considered hard to transfuse. She is that patient that more than likely they would need to fly blood in for. The last time she needed a transfusion, we had to wait because the blood was coming from New York.
Right.
So that just, and there are so many patients like her across the country. If you're in an emergency situation, can you imagine what it would be like if you needed blood and there was no blood? That's deadly. So for that and so many more reasons, we encourage people of African descent to come out for the sickle cell community.
Yeah, I was just going to say that, I think what you and Dr. Ward kind of touched on is that, this is how I and UBI kind of perceive as blood donation, is that this is a social justice, health equity issue. This is not just your civic duty, it's your moral duty that if you can donate, you should donate, because exactly for the reasons that we're saying, and donate locally, because more than likely you live in the same area where this patient is, you're more likely to have the same antigen profile, and that's especially critical again for patients which have complex needs for transfusions, such as sickle cell patients. So it's really, when you think of donation, it's not that's like, oh, I'm just gonna donate blood, I get a cookie. It's this such a significant event that you're making in someone's life, and you are helping in your own little way in that one moment. And by making that repeat commitment to say, I'm going to come back, I'm going to schedule my appointment, I'm going to make sure I'm in time, I'm donating platelets, I'm donating plasma, I'm donating blood, whatever they need, you are making a commitment to making this world a legitimately better place for somebody else. And that's what social justice is. And you're fighting, again, health equity. And it's such a major thing. I think when we say, when you save a life, that phrase is thrown around, it sounds so mundane, but like, yeah, it's just everything to somebody.
Yeah,
really.
yeah, it's absolutely true. You are saving a life when you donate blood. And I'm not sure if donors realize, though, when they donate whole blood, they actually can affect more than one patient, because we separate the red cell component from the liquid component. And so you can be helping more than one patient just from one blood donation.
Yes, and oftentimes I think people don't realize is that patients need it frequently, constantly. Yes. They're chronically needed. So I think people just figure, oh, I'm gonna donate and that one time and I'm good. But imagine if you're the match for someone,
right.
And every month, more than likely, what are the odds of someone's blood going to that one patient every month?
Yeah, and I think
possible, Doc? I don't even know.
So yeah, so whole blood, there is a deferral period, because we need to have donors rebuild their red cells on their own. So it's an 8-week deferral period for blood donation. But you're absolutely right. So the actual blood, it has an expiration date. It only lasts for so long. So it's a constant need of replenishing the blood for patients.
Yeah, and I guess, again, to put it in the local context, again, when we donate local, it stays local when you're a local independent center. So if you live near UCLA, donate to UCLA.
Right.
But going back to the more serious note, is that this blood's going to people like the teacher in your school who was your favorite class teacher, who made you want to go into science. It's going to the mother like Mapillar with 3 children who needs to be healthy so she can take care of them. It's going to the person who takes care of the community garden. And when these people can't get blood, they get sick, and it slowly weakens, what are our beautiful communities around this country. So when you donate blood, you're saving a life, and you're making your community happy, healthy, and you're making sure the people who are a part of it, who make it the place that it is to live, can continue to do that. So if you want to think about it that way, that you're keeping your community going strong and your favorite people in it, because we never know who you're going towards, for patient privacy and patient safety. But if you want to think of it as when you're donating, think of your favorite person that in that community is going towards them. Think of it that way, because that's in essence what's happening. Someone who you're donating to, that's someone's favorite person who makes their life special.
Absolutely.
And I think to that point, what I encourage patients and families to do is to share their story. Oftentimes, I think by nature, we are decent people. Like, if you know that your neighbor relies on blood products every month to lead as normal a life as possible, more than likely, when you are at that defining moment, when you see that blood mobile at Walmart, you will think about your neighbor. The odds of you donating will be greater. So sometimes it's just about giving people a why to act. And that starts with sharing our stories, especially if you are like my daughter, knowing that you rely on blood products. Give your community a chance to help you. Go into your places of worship and share your story. Go to your local school, share your story, so you can give them a why. You help that local school be able to get more people out to donate because one of their own needs it.
No, 100%. And that is something that our local chapters are working on doing, especially in September for sickle cell, but all month long. So I guess if people you're watching are near one of our chapters, which you can find on our website, reach out to them. They'd love to help you tell your story locally to touch again your local communities. And we at UBI are going to be interviewing other sickle cell patients this month to gain other perspectives on this issue. But enough for my well, I guess not shameless. I guess there's a good plug, but of my shameless plugging, let's go on. So again, we've touched on it. You guys are clairvoyant. You know what I'm saying already. So we talked about, I guess, some of the dangers of having constant transfusions. Again, the iron overload and the antigen, the fear of developing antigens and then having a reaction to that. But I guess would it be possible? I guess like when you build up antibodies, what does that mean? Dr. Ward, what does that mean for future transfusions? I guess what are the complications? Let's say you have that reaction. What can happen to somebody?
Right. So there are risks to blood transfusion, right? And we've kind of touched upon this. A couple of different things. One is transfusion reactions. So transfusion reactions, there's different types of reactions that can occur. What we were alluding to earlier was the reaction in which the patient's body makes antibodies to antigens. And where that can really be challenging is if, for example, you need a blood transfusion and you're not able to match the blood to the patient. And if the patient has an antibody to the antigen or the protein on the red cells, then their body will react to it because they know it's foreign, it's not supposed to be there, so it's going to want to clear it. And what can occur with that is what we call a hemolytic transfusion reaction. So in that case, the red cell, the donor red cell, is actually hemolyzed or broke open, or the body's trying to remove it. And when that happens, that free hemoglobin can cause different signs and symptoms for the patient, which is particularly dreadful, I guess, for sickle cell patients because they already have an underlying release of their sickle cell. So adding that, a donor transfused red cell lysine or hemolyzing in addition to the underlying hemolysis that's occurring can really be hurtful and cause organ damage. People usually have fevers. They can have chills. But as I mentioned, the organ damage is usually the most severe, and that could affect kidneys with having that free hemoglobin. So that's one type of transfusion reaction. Other reactions could be allergic reactions, right? So the person could actually just be reacting to some of the proteins, around the red cells and cause, it can cause like swelling of the lips or tightening of the throat, hives, itching, allergic reactions. And then there's more severe reactions that can occur as well. So that's with the transfusion reactions. Now, the unfortunate thing with making antibodies is that once you've made antibodies to red cell antigen, then moving forward, all of the red cells that you're transfused should be negative for that antigen that you've made antibodies for. So for Mapillar, in her own experience, her daughter has made an anti-JSB, which is highly prevalent. So now we have to find the 1% of the population that does not have that JSB antigen. We need them to donate blood, and then we need to fly that blood to the hospital that Mapillar's daughter's in if she needs a blood transfusion. So that could be very difficult logistically to occur. The other thing is some people make multiple antibodies. So it may not just be the anti-JSB that they've made. There's other red cell proteins, antigens as well. And so you can make multiple antibodies to these antigens. And then it's even more difficult to find people that are negative for all of those antigens. And then we need that person to donate the blood, to get it to the patients. So, so when patients make antibodies, it can be very challenging to get the correct blood or the matched blood that they need to actually help them, because we want to provide antigen negative blood to the antibodies that you've made. It's very challenging.
Yeah, I mean, again, I guess I love doing comparatives today. But again, it's like organ donation. We all know like the level of rigor that it goes to matching. Like blood is no different. That's why if you can do it, give it a shot, because we truly the level of matching that needs to be done is truly insane for some patients, and it requires everyone to just put in like their ballot into the box, I guess. Again, I don't know, my descriptions are horrible. I hope you guys get what I'm saying here, but yeah, again, that's why every single donation matters, because truly there are so many different variables at play when it comes to matching complex cases. And again, for those of you here who maybe aren't of African descent, there are lots of other illnesses which are similar scenarios to this. This is again, sickle cell, very important, but like if you're inspired by this talk, your blood also counts very, very much to somebody else. So just to move on, so we talked about sensitization. So you guys are just reading the mind. We're just covering everything. I'm just like way to go. So I guess just to highlight, I guess we touched this a little bit earlier as it's one of the themes of today's conversation, but what are some of the biggest barriers of recruiting donors of color, specifically African Americans in this country? And again, I guess you guys have, different but overlapping experiences to touch upon here. And I guess what can people do, especially our audience, which is mostly young people, what can we do to help mitigate some of these barriers? What can we do to push this forward? And I guess you have advice for our chapters on things they can do or approaches they have to take, that would also be really welcomed.
Right. So the barriers, I think, some of them are just historically what has occurred with African Americans in medicine, right? Even though for blood donation, you're actually like we're not giving you a shot or giving you a medication, you're actually the one that's providing the red cells for us. I still think that there's, some fear and distrust around that. And so what we've tried to do at UCLA is work with our different student groups to mobilize people of color to come and donate. So, different groups on campus, whether it be, specifically African American groups, to just spread the word about blood donation and take the fear away from it. Mapillar also mentioned going into churches. So churches of color, having a patient speak about their experience is very powerful and it works. And as I mentioned earlier, the hematology and transfusion medicine community, we really need to just do a better job at dispelling the fears that people have with donating blood, and spreading the word on the need for the need for blood from those communities. It is challenging though. You try to start young. You try to start with kids while they're in high school, and then hopefully they'll continue to do it into adulthood. But there's definitely a fear and a stigma with the Black community in blood donation.
I think that was perfectly said. I have nothing else to add. Yeah, we have to keep engaging. We have to be persistent. That's really all it's going to take. People have to have a why.
Right.
Okay, sounds good. So I guess to kind of cap it off, I guess on a very fitting note, is we want to talk a little bit about Mapillar and about your personal experience with sickle cell. Again, we've kind of touched on it in various forms of this interview, but just to dive in a little bit more and to give people who are watching, like these are the people in your community who are suffering and what they go through, and I guess some of the more social detriments. Again, what is a very devastating disease. So I guess aside from the physical illnesses, like how has this affected your family? Again, you talked about economic and social burdens and so on and so forth. And if you feel comfortable, illuminating this just again to give people a perspective, I think that'd be appreciated.
Where do I start? Well, as one would imagine, having all three of my children have sickle cell disease, so it really is our life. We are impacted by this disease every day. Right now, the kids are home virtually doing school, even though they want to be in the classroom, but their health comes first during the pandemic. But sickle cell has been just, I always describe it as I'm that mother and there's this big old giant in front of me trying to take my kids away. And I'm like, you cannot have my kids. And now that I'm running the organization, you cannot have his kids and her kids. Like I'm trying to fight against this giant because I see what sickle cell can do to people. I've through my advocacy, we've lost so many sickle cell warriors, young and old, and it's a really deadly disease, and it makes no sense that it is not giving enough compassion. It's not giving enough funding. It's not giving enough sensitivity. So for me as a parent, as a caregiver, when, for example, when my kids were younger, they were in the hospital a lot. And I got fired from a number of jobs. When we talk about insensitivity, I got fired from a number of jobs because I chose to be with my kids who were in crisis. You know, I should not be worried about my job when my kids are in a hospital. But because people are not sensitive to the plight of sickle cell patients and their families, that was my issue. And we talked about the stroke. My daughter having a stroke at 7 blew my mind. Just having to navigate life post that, being introduced to the world of blood transfusions. I think people think about transfusions. Earlier, I think Doc said it can, with apheresis, how it shortens the time of getting a transfusion. But for a family that's having transfusions, because of the need to cross match, we typically cross match, and to make sure you're not staying at the hospital all day waiting for blood. Transfusion for us looks like a day or two before she's actually due for transfusion, we have to go to the lab so that they can, be able to cross match her blood. And then the day of transfusion, we wake up at 4:30 in the morning. We're in Atlanta, so we're trying to get a good head start before traffic starts. So her transfusions start at 8. It's a good day when we get home by 4, because there are those times when everything doesn't go well. Her port may be malfunctioning and they have to do intervention. And we pray that it works, because if not, that means another surgery. Within the last 8 years, she's had about 10 surgeries, one of which was a major brain surgery to, try to repair the damaged blood vessels from her stroke. Learning that your daughter is hard to transfuse, that was crushing. And it's weird because for me as a parent, I was like, how crazy it is that I have to say, thank God that this is not her sister who needs transfusions every month.
Right.
That is the only blessing in this. It's a hard disease. I really try not to think about how overwhelming it is. I just try to one day at a time it. And in the process of this, not seeing support and help for sickle cell families. That's why I do what I do through my organization, with helping families pay rent, with utilities, because those are the kind of help that I've needed in the past and have looked around and didn't see it. And just trying to be that source of support to other families, essentially doing things for others what I hope people will do for me.
Yeah.
Because the need is so great. I will stop there because I'm getting emotional. But sickle cell is my life, and I am very passionate about using my voice, my energy, my talent, everything that is within me to really help educate people about this disease, because I feel like the worst thing that has been done with sickle cell is the fact that the powers that be did not educate our people who are so predominantly impacted by this disease, did not educate us about the basics, which is, first of all, let us know if we have the trait or not.
Yeah.
And if we do have the trait, what does that mean when it comes to procreation? The fact that that was not done is wrong, and we have to change that.
Yeah, no, thank you for that really honest and powerful response. Like, yeah, it takes a lot, like you said earlier, it does, when you share your story, I mean, it does take a lot of courage because, and people, they're like, oh, you're brave a lot, but it's scary to put yourself out there, like you just did. But I would like to give you the opportunity to talk a little bit more about like your very wonderful organization, which is My Three Sicklers. And again, you kind of talked a little bit about, about the work that you do and like it's like why you were inspired from your own struggles. But if you'd like to talk about, your foundation in general or some of the work you do, I really want our audience to be aware of what you can do. And maybe somebody out there watching this will see this and say, oh, there's someone I can turn to, or they will share it. And I think that's really important here. So please, if you have anything to add, we'd love to hear it.
Yes, it's a labor of love. And like I said, I started the organization because there's just not many people lined up to support sickle cell families. And I think oftentimes because we're so used to suffering in silence, we just go by our day and just keep on struggling. And so the organization is MTS Sickle Cell Foundation. And I have always been passionate about awareness. I am originally from Liberia. Doc, that's why I asked you if you're from Liberia.
I might be. I'll have to figure that out one of these days.
I'm originally from Liberia, and that's West Africa. And when I fell into this world of sickle cell, it dawned on me, and seeing how prevalent it is around the world, I was like, why did I not know about this? Why was it not talked about? And so even before I started my organization, I've been very intentional in sharing our story. When my daughter had a stroke, everyone that's on my social media, they got to see that, this is what we're going through. Because sometimes when you're, teaching textbook style, people they kind of tune you out. But they got to see what sickle cell does to people. Sickle cell caused a stroke. Sickle cell did this. Sickle cell did that. And but what really made me start the organization is the fact that we need support. So I travel across this country. Well, now I Zoom a lot in educating, but in the background, what people don't get to see is the checks being written to help people pay their rent or buy food or help bury a sickle cell warrior that has passed or, help with utilities. But there are things that people get to see. And it's stuff like the camps that we sponsor kids to go to over the summer. We do different things. Like right now we're doing care packages, and our support is national. When I first started, it was just Georgia because that's where we are. But then as we became more known, thanks to social media, that created a social burden to help other families because they don't have those kind of support over here. So now I say, if we have the resources, you can get it. It doesn't matter where you are, as long as you're in the United States. I have a feeling it's going to be global because our audience is now global. And I kind of tapped into the global audience last year. I sponsored 2 international organizations. I gave them grants to have events in their community, 2 organizations in Africa, because they were doing a holiday breakfast. And so I sponsored their events so that, those families can benefit from us in some way. But so the organization is, we're passionate about just making sure that families don't feel like they're alone in any of this. To know that if you're needing help, there's an organization here that you can reach out to. And if the resources, I always say if the resources are there, because child, sometimes it's tough. Sometimes it's tough. People are not as giving, but we're gonna change that. we're gonna be persistent. If the resources are there, it's an honor to service the sickle cell community.
Yeah, no, I definitely feel you on the resources and the people giving. We are going to be persistent together, and we'll be on the global stage together. You and I think UBI and MTS Sickle Cell Foundation. I think we'll have a long future together because you do amazing work, and behind the scenes, you are a lovely, wonderful person who deserves everything wonderful to happen to them and their family. I guess to end the call, because we have gone over, and so yes, thank you for both of your times for staying late. I guess, Mapillar, again, you've talked to so many people, you've helped so many people from here in America or here in Africa. I guess, are there anybody's stories who you've met that really have stood out to you? And this can be in terms of resilience or things they've overcome, or any topic that it comes to mind to you.
I always say I'm inspired by all patients now. Sickle cell patients are some of the toughest, and Doc, I'm sure I hope you can agree with me. the things that they go through and still be able to smile, or just put one foot ahead of the other and keep going. They're so resilient. But there's this one little voice that has stuck with me. We were at a sickle cell education day. This is before I even started my organization. And we had just seen a panel discuss living well with sickle cell, and it was time for questions, right? And so this little boy, he couldn't have been more than 12 years old, and it was his turn. He got the mic, and he started off by saying how he gets to see all of the wonderful things that's done for cancer. And he mentioned cancer because you have to understand that sickle cell patients and cancer patients are seen together. Mm-hmm. Yeah. And I often say that by osmosis, our kids get loved on because they're seen with cancer patients. Mm-hmm. So for example, if my daughter is hospitalized, she's gonna be on the AFLAC floor, which is where cancer patients are seen. And they spoil those kids rotten. But all of those amenities are because of cancer. So this young boy, he says, we get to see everything that is done for cancer. What about us? Just that question. I couldn't even tell you what he looked like, but that question has carried me. What about us? What about sickle cell? What about taking us seriously? Mm-hmm. What about us that you don't believe when we're in pain? What about us that you don't want to help? Send us to camp or, help us when we're in crises or when we're needing more socioeconomic help. What about us? He wasn't saying any of that. And so that little boy, I don't know his name. I probably don't know his face anymore, but I remember his question. And yeah, that will be the patient.
Yeah, and I think that's it. And not that it's uplifting. I think it's an insightful question to end on, in that, cancer got started because Dana-Farber and Mary Lasker said, hey, this is being ignored. These children are suffering. Let's do something about it. And I think in the same way, we can say, hey, these children have sickle cell. They're suffering. Let's do something about it. And in one immediate way you can do about that is, again, donating blood, sharing people, the foundation if they need help, talking to people. If you can't donate blood, telling others, and even if you can, also still tell others. No excuse not to talk. it's only going to get the attention that we can get it, but we all come together. But with that, thank you guys for your time. This was a great conversation. I learned a lot, and I hope this was enjoyable for both of you.
It was. Doc, it was so nice to meet you.
Yeah, thank you so much for having me here today. And Mapillar, thank you so much for all that you're doing. I'll continue to advocate for sickle cell patients, and as trainees, come through medicine, continue to, push for them to be sensitive to sickle cell patients. And yeah, thank you UBI for having me today.
Okay, guys, have a lovely evening, and to people watching, same to you. Bye, everybody.